which is in the anterior vaginal wall 3 cm proximal to the external urethral meatus, and it can range from -3 in normal individual to +3 in a completely prolapsed patient. BA is a most dependent part on the anterior vaginal wall. It can range from -3 to the plus total vaginal length. And C is the cervix or vaginal cuff. So cervix will be there in a patient on whom hysterectomy has not been done, whereas if the patient has already been hysterectomized, the point C will be the most plus or minus TVL, or it is the deepest point in the vaginal cuff. And D is the posterior fornix or the vaginal apex, which corresponds to the attachment of uterosacrals on the vagina, or there is a small dimple at the uterocervical junction where uterosacral attaches. And AP is the posterior vaginal wall, midline 3 cm proximal to the hymen, and BP is the posterior vaginal wall, most dependent portion, and it can range from -3 to plus total vaginal length. Now there are 3 lengths which is called as GH. GH rise from external urethral orifice to posterior hymen remnant, and it is a distance measured in centimeters. TVL is also a distance measured in centimeter from hymen ring to point D, which is the attachment of uterosacrals or the highest point in the posterior fornix. And perineal body is the length in centimeters measured from the posterior hymen to the middle of the anal opening. This is the length of the perineal body. And measurements are taken using a marked spatula, IR spatula, which has been marked with centimeters, or we can even use a sterile scale, and the patient is examined in a dorsal position while doing the Valsalva maneuver. Total vaginal length is measured after reducing the prolapse, and the values are marked on a 3x3 grid. So this is the point AA on anterior wall, BA on anterior wall, the position which can range from -3 to TVL, and this is the position of point C, and genital hiatus, perineal body length and total vaginal length, the point on the posterior wall and the point on the posterior wall, and the point D in the posterior fornix. So what are the indications of urodynamic studies in a patient with recurrent vaginal prolapse? So if the diagnosis is uncertain and there are major discrepancies between history and voiding diarrhea and symptom scale, so we do not know what incontinence we are dealing with, whether it is urge or mixed or stress or it is overflow, then we have to do the urodynamic studies. If the post-voidal residual urine after doing an ultrasound after the patient has voided is high, then we have to do a urodynamic study. If there are associated neurological conditions like multiple sclerosis leading to a recurrent prolapse, then we have to do a urodynamic studies. And if there is a previous surgery for incontinence and the patient has become incontinent again and prolapse has recurred, then we need to do a urodynamic study. If there is a coexisting anal rectal prolapse in the patient, then we have to do the urodynamic studies.